have any questions, please type them into the question box up at the top right hand of your corner of your screen, and I will pop on intermittently to ask the doctor your question. And then please see the paper clip at the top right-hand corner, and that is where we have attached handouts related to today's presentation. So with that, I'm going to ask Dr. Sable Smith to turn on his camera and log on, and he will talk a little bit about his background and his expertise in this arena. Good afternoon, Doctor.
Hi, Drew. Thank you so much for the introduction and the opportunity to speak to everyone. It is, I'm someone who really values relationships and working collaboratively. And, in work comp, there's a lot of cooks in the kitchen always, but we rarely actually talk to each other or interact. And so I really welcome any opportunity to get to know the other folks in this space, since we're all doing really challenging work, and it usually goes better when we work together.
Absolutely. Well, it's great to have you on. We appreciate it, and I know that all of our audience is going to appreciate your expertise and your willingness to partner with us on some of these challenging claims.
Fantastic. So yeah, I'll tell you a little bit about my background. So I started off as a family doctor. I did my residency in family medicine, was going to do primary care. And eventually, by the end of residency, I was realizing that primary care wasn't the best fit for me. I worked a lot in the hospital and was taking care of people with serious illness. And long story short, I eventually did a fellowship in palliative medicine and worked at the VA for a year. And through that, I developed an interest in pain medicine. Went back and did my second and hopefully final fellowship in pain medicine. I finished that in October of 2020, right in the middle of the pandemic. And I've been working as a pain management doctor ever since then. I am located in the Bay Area. I live in San Francisco, and I do both treatment in workers' comp as well as medical legal work. So I treat at a practice called Feinberg Medical Group, which is in Palo Alto. And I also do medical legal work all over the Bay Area, up to San Jose, Tracy, Sacramento, Stockton. And I work with an organization called Forensic Medical Legal Evaluators in helping manage my medical legal work. So I've been doing all this for almost 4 years now, and it's been quite a steep learning curve from the beginning. So today I'm going to talk about chronic pain, and I'm going to talk about it kind of more in general terms, because it's something that is so common. You hear about it not just in work comp, but throughout the country and the world. Obviously, it's a big issue that affects more than 100 million Americans. But it's something that a lot of us have experienced or know people who have experienced, but we even doctors still don't have a great understanding about chronic pain. We've all experienced acute pain, but we don't really know about chronic pain. And so that's what I want to achieve today in this presentation. If I can advance the slides here. So I'm going to define what pain is. I'm either going to review or introduce you to a model of assessing and understanding pain called the biopsychosocial model. And I also want you to understand how a pain management physician like me assesses and treats chronic pain in the work comp system, as well as identifying barriers to recovery and opportunities for effective recovery in the work comp system. I touched on this a little earlier, but pain affects a lot of people. It has a huge impact on people's lives, not just their work ability, but their ability to have relationships, to see their friends, to do the things they enjoy. Specifically within work comp, chronic pain is a big deal. So it's a relatively small number of injured workers who are high utilizers, who end up costing the system a lot of money. As always, the goal with treating chronic pain is to be efficient and cost effective, to be as evidence-based as possible, to speed an injured worker's recovery and their return not just to work, but to life. And what I have to say about this is easier said than done. So what is pain? And we'll get into the definition here. So pain is it's a universal experience. We've all felt it. But defining it and measuring pain is something that has really vexed philosophers, scientists, and doctors for centuries. And chronic pain especially remains one of the most complex medical problems that burdens society. So before we start talking about what pain is or how to define it, it's important to also think about why we feel pain. So pain is nature's way of getting our attention to tell us something bad is happening. So when we feel pain, it motivates us to change our behavior to avoid the painful thing. So think about our ancestors when they were cave people. You break an arm, well, it hurts when you move it, so it motivates you not to move it. That's important for survival. You want to keep that arm still so it has time to heal. If you get painful attack by a lion, you will not do that again. Pain motivates you not to come so close to a lion again. So pain is this really crucial part of our survival instinct as people. And in fact, there are people who have a genetic mutation that makes them unable to feel pain. And unfortunately, these people, they die early because they get injuries that they don't realize they have, and they go untended. So pain, as unpleasant as it is really important. Now, how do we experience pain? So this is a model from Rene Descartes, who was a 17th century philosopher, scientist, and he was one of the first people to try to explain what happened with pain, how we experience pain. And so he thought that there was some sort of, you could think of it as a bell attached to a string, and when you got close to something that was dangerous, like in this case, a fire, there was some tube or string in the body that was activated or pulled like this, and that it rang a bell in the brain telling us that there was something wrong. And so then the body could, move your foot away from the fire. And in this way of thinking, pain was very much something that happens to us and something that we don't have any control over. And this is really how society has thought about pain for hundreds of years, and is still how most people conceptualize pain. That is because we're thinking only about acute pain. So usually when it comes to acute pain, there's a proportionality to the injury and the amount of pain. So if you lightly stub your toe, you'll feel a little bit of pain. If your toe gets amputated, you'll feel a lot of pain. The flip side is kind of a lot of our logic about pain too. So if you happen to be feeling a little bit of pain, well, you think it must mean something's just a little bit wrong. Or if you're feeling a lot of pain, it must be something is seriously wrong. And like I said, this is how this is the kind of human logic of pain. But there's actually some curious and interesting counterexamples that have really kind of turned this theory on its head, or at least poke some holes in it. So to illustrate this, especially when it comes to acute pain, I'm going to relay the tale of two nails, which I read in a book from Elizabeth Zoffness, but was actually published as a case series. So the first nail on the left here, you'll see a nail through a boot. This was a construction worker who I think had fallen off some scaffolding and landed on the ground, looked down, saw this nail going straight through their foot. They experienced excruciating pain, got on the ambulance, took them to the hospital. They took off the boot, and lo and behold, the nail had barely grazed the person's skin. It had gone between two toes, and had not pierced the foot as they had thought. So this was a relatively minor injury, but the person experienced severe pain. So why is that? Here's a counterexample, even more dramatic if you look at the right picture. This is someone with a nail in their skull. So this construction worker was using a nail gun, and apparently it misfired, and he saw a nail shooting across the room. He went about his day, finished the job. A few days later, he was having a toothache. Wasn't getting better, went to the dentist actually. X-rays were done, and they revealed this. So what had actually happened was when the nail gun misfired, one nail shot forward and the other shot backward and actually had gone, I think, through the person's mouth and lodged in their skull. It was not in their brain, fortunately. There's a lot of other space in there. And, to him, he thought the nail had gone across the room. He didn't think that there was something wrong with him. And it took this toothache, which wasn't that bad to begin with, to get him to seek medical treatment. So that illustrates how pain isn't always proportional to the amount of tissue damage, even with acute pain. Another phenomenon that you might be familiar with is phantom limb pain. So this is someone who has had an amputation and they continue to experience severe pain in the limb that has been amputated. So the pain is real, but there's no damage going on because they're feeling this, say, in a foot that's no longer there. So that illustrates that the pain is much more complex. We know from imaging studies that there is often not a strong relationship in cases of tissue damage, or what we can see on imaging, and the amount of pain that someone's experiencing. So you might have two people with the same X-ray. This X-ray shows a little bit of degenerative changes in the lower lumbar spine. You can have someone with these X-ray changes and not have pain at all and work on an elite level. And you might have someone with the similar X-ray who has debilitating pain, who can't work at all. This is something that physicians know very well, that imaging findings don't always match up with the amount of pain that someone feels. This is a kind of famous study of MRI. So essentially what researchers did is, took a bunch of people who had no back pain and did MRIs on them, on their low backs. And so what these percentages are the percentage of people in these different age groups who had these findings on MRI, even though they didn't have pain. Let's look at disc bulge here. So 30%, they found 30% of 20-year-olds had disc bulges or protrusions, yet were still asymptomatic. Go up to a 50, 60-year-old, and the almost 2/3 of people will have but 2/3 of asymptomatic people can have disc bulges and disc protrusions. So when let's say someone has back pain and we do an MRI, let's say we find a disc bulge or disc protrusion, it doesn't necessarily mean that that's the source of the pain. And that's kind of hard to compute for a lot of people, especially because we can be really desperate to find what the cause of this ongoing pain is. So ultimately, people who study pain realized that this old model of pain, it wasn't complete. It doesn't really take into account the inconsistencies that I talked about. So this new way of thinking about pain and the phenomenon of how we experience pain, called the biopsychosocial model, was proposed. So this model, it takes into account that the mind and body are very much connected, so that a person's experience of pain is way more complex than what's going on in the body itself, or the damage that's going on in the body itself. So um, you can't just consider what the pathology is, like the disc bulge. You also have to consider who the person is, how this person thinks, what their emotional state is, or the psychological component of their existence, and what is going on in the environment around them. So this is the social of the biopsychosocial model. And we've found that pain really impacts our emotions and how we function in our social roles, our thought patterns, and other psychological factors. And likewise, all those psychological factors and effects on our social roles can have big effects on pain. So it's this kind of two-way street. And brain imaging, functional magnetic resonance imaging, functional MRI has shown us that pain and emotional processing actually share a lot of real estate in the brain. They use the same brain areas, so there's a big overlap, not just in what we see and experience, but it actually is going on in the brain too. A really important part of this new understanding of pain is that pain's not just something that happens to us. It's a two-way street, meaning that the mind plays a crucial role in shaping the experience of pain. This is just a Venn diagram kind of representing the biopsychosocial model. So pain isn't just the result of tissue damage. It lies in the center. Pain is this complicated phenomenon that happens in response to biological changes, our psychological state, and social issues. So if you think about injured workers, I mean, you can have all spectrum of injuries from not a lot of tissue damage to really severe tissue damage, but you know how much a work injury can kind of turn someone's life upside down. Their income is cut. Even a lot of people don't get the disability benefits. Countless numbers of my patients have to move out of the Bay Area and kind of uproot things because they can't afford to live here any longer. That does a lot to your mental state, and that in turn affects pain. This is actually the scientific definition of pain. It's an unpleasant sensory and emotional experience associated with or resembling that associated with actual or potential tissue damage. You don't need to remember that, but the point is, even the scientific definition of pain is something that is sensory and emotional in nature. There's a ton of ways we can classify pain. Now that we know what it is, we can classify it as based on time course. So acute pain is usually less than 1 month in duration. Chronic pain is usually 3 months or more in duration. The body is very good at healing itself, and most injuries heal in this like 6 to 8 week time frame. And so, you might have had surgery or broken a bone in the past and know that the pain's very intense at the beginning, but it tends to get better as time goes on and the body heals. Acute pain, it has this biological value, like we talked about. It's a warning sign telling us it's keeping us safe. Chronic pain, so pain that persists even after the normal healing time, that really often doesn't have a biological value. You know, this pain may be telling us not to move because we're scared of re-injuring ourselves, but that can keep people stuck in this cycle of disability. And more so with chronic pain, the traditional biomedical approach can be pretty disastrous, and we'll get to this later. Another way to define pain is in terms of what part of the body the tissue damage is in. So nociceptive pain, this is when there's tissue damage that's not a nerve, so like a broken bone or a torn muscle. Neuropathic pain is when the tissue damage is to a nerve itself. Most classic example would be radiculopathy or a pinched nerve. So there's a big disc herniation that's really squeezing a nerve as it comes out of the spine. This is neuropathic pain. And there's this other type of pain, which is a little harder to understand. This is called nociplastic pain. So this is the pain that results from a sensitized nervous system. So when you'll see this with a lot of people who have been living in chronic pain for a long time, they'll, even slight movements will cause a lot of pain. And we think that is this nociplastic phenomenon where all these changes in the brain and nervous system are basically creating this pain experience, even when there's not a lot of tissue damage. And people don't always have just one type of pain. Most of my patients have an element of all these types of pain. So let's talk about pain assessment. So when I am seeing a person who has chronic pain, a really comprehensive biopsychosocial assessment is of the utmost importance. So a way to simplify this, and this is the title of the presentation, is I need to figure out what is the hurt and what is the harm. So assessing harm is something that all doctors are really good at. We have all these fancy tests that can help us determine what the extent of tissue damage in the body is. In basic terms, we can get an X-ray that shows us, is the bone broken or not? Does someone have severe arthritis or not? We have MRIs that show us soft tissue injuries, nerve tests. We have so many tests we can do to help define tissue damage. On the other hand, I also, and maybe even more importantly, need to determine what's causing the hurt. So what I mean by this is, what are the factors that are contributing to someone's overall suffering? And this is something that doctors are really bad at. Because it requires something that's even more rare in healthcare settings than the fanciest MRI scanners. It requires time, sitting down and talking to a patient and really understanding who this injury has happened to, and not thinking of it just in terms of how severe the actual injury was itself. So when I'm assessing someone, yes, I'm looking at the scans, I'm doing a physical exam, but I'm also trying to get a sense of how this injury has impacted someone's life. Often when you do that, you uncover a whole lot of other factors that are contributing and to someone's kind of state of high alert. All right, I want to give two real cases. So I'm not sure if I think you can all see me, but about a year ago, I saw a new patient. He was a young guy, maybe 35. He had been in a car accident, which was work related, and he had whiplash. So, it wasn't a devastating car accident, but his neck was sore. He experienced a sprain of the cervical spine, some muscle spasm. By the time I saw him, it had been, I think, a year and a half since the injury, and his pain just hadn't gotten better. So he walked in, basically with his head held against his shoulder, so still, barely moving at the neck. He just looked so scared. And what, I looked at the scan and it wasn't, his MRI didn't show anything that severe. So I did what I have learned to do and really get to know, like, okay, what's going on here? Well, it turns out he had this initial injury, it didn't get better. PT maybe helped a little bit, but he still had spasm. And, he had tried medication, still wasn't getting better. And a well-meaning physician who he had seen before, but maybe with not excellent delivery, when the patient asked him, well, why am I still hurting? The doctor, not really knowing what else to do, said, well, I don't know. I guess you have the neck of an 80-year-old. And so for like the next 6 months, this young guy had been living in fear that his neck was like severely damaged and could crumble at any moment. And so that was keeping this fear was keeping his nervous system on high alert. Any movement of his neck would cause excruciating pain. So I sat down with him. I opened up the MRI images, looked at them with him, and basically reassured him that no, your neck in no way is that of an 80-year-old. That I reassured him that he is safe. That even if he was feeling this intense pain, it didn't mean that his neck was going to crumble. He was going to go paralyzed. And that, 45 minutes of time was well worth the investment. Like over the next few times that I saw him, he was able to get back into PT. He was way more relaxed in the neck. And when I had told him that, he wasn't going to crumble, he actually started crying because he'd just been living in all this fear. So understanding what the root of the suffering was really important in this case. Here's another case which is the opposite, and I'm borrowing this from my colleague Dr. Steve Feinberg. Some of you may know him, but he had seen someone as a QME who had, I think, 19 back surgeries. So I think the initial injury hadn't been that severe. I mean, maybe there was a disc protrusion or radiculopathy, and this person had gotten surgery, but it hadn't really helped her pain. And then she got another surgery, and that didn't really help her pain. And then she got another surgery, and that didn't really help her pain. And each time the surgeon would say, oh, well, we fused this level, but you're probably hurting from the level above this. And it just kept going on and on until she had all these back surgeries. And by the time she got to Dr. Feinberg, I think the surgeon was recommending another. And Dr. Feinberg was like, well, what makes you think that this next surgery is going to be the magic bullet after all these others? And this is an all too common scenario, maybe not as dramatic in most cases, but a very common scenario in medicine, where we just focus on the pathology, what we can see on imaging, and not focusing on the whole person. Now, I don't know what all the other factors contributing to suffering or to the hurt in this individual, but I'm guessing that a lot would be uncovered if people took the time to really understand her and this person who was going through this awful process. All right, talking a little more about psychosocial factors. There are a ton, and it's simple to say you just try to understand who this person is and what's going on with them. It takes listening. We have some tools and questionnaires to try to understand when someone has a lot of psychosocial suffering. For example, we try to assess something called pain catastrophizing. This is where people can develop really kind of black and white or worst case scenario thinking about pain. I'll never get better again. I'll never be able to pick up my grandchild if I can't run the marathon that I wanted to run. And that can be real, like someone who has that type of worst case scenario thinking. It's really hard for them to break out of that cycle. So there's we'll get into this a little later, but there's ways to try to help people see a little more nuance and gray in their situations. Another really important thing to assess is kinesiophobia. This is a term that means that how fearful they are of re-injury. So my patient with the neck spasm, for example, he's someone who had a high amount of kinesiophobia, fearful that he was going to re-injure something, and that was helping kind of maintain this pain state. And so it's really important to understand what someone's beliefs are about their pain. There's a lot of system-related factors that can impact someone's recovery. And so this is all too familiar to all of us, but this is a really complex system. And, I don't think anyone's trying to do any harm in this system, but basically every step along the way, there's things that can worsen the suffering associated with an injury. So when people face treatment delays, everything, I have to get Tylenol to go through UR, and that creates delays. And while someone is delayed in their treatment, they may be misinterpreting why it's being delayed. A lot of people, don't really understand that things have to go through this review process. They think, they harbor resentment against the employer and think that maybe the insurance is intentionally delaying treatment. Well, all that just kind of revs up pain. Sometimes people see doctors who really just focus on pathology, and they just focus on what's wrong on the MRI, and so that can lead to the person who gets 19 back surgeries. It can also lead to someone who has a really serious diagnosis that gets missed just because people are focusing just on like imaging studies. So I had an injured worker who had really bad CRPS of his arm, and no one was really doing a good exam of his arm. His imaging was normal, as it often is in CRPS. And they said, well, there's nothing wrong. You need to go back to work. I saw him months after that, and he just had like this balloon hand, like one of the worst cases of CRPS I've ever seen. And that really had a negative, that whole experience had a really negative effect on his recovery. Sometimes people have attorneys who really don't support. I mean, most attorneys are good and support someone through the system, but there are a lot who don't. If the person ends up with a bigger settlement, the attorney makes more money too, and that I think can have an effect on an injured worker. There's a lack of communication between all stakeholders, so the doctors, the adjusters, the attorneys, and there is, this is tough work and really, quite frankly, frustrating work. So there's not a lot of medical providers in the system. And then finally, we can categorize these psychosocial factors into patient-related factors. We've kind of gone over all this, but unrealistic expectations, fear of re-injury. One to highlight here is adverse childhood experiences. And so there have been studies of this, and when you look at people with chronic pain and assess them for abuse or neglect during childhood, there's an incredibly high prevalence of that. And we don't know exactly what the link is, but something about experiencing trauma during the time when your brain is forming really has a huge impact on how someone responds to threat and injury as an adult. And it's just really shocking, the correlation between these two things. So what can we do about it? You know, on my end, I try to understand what you know, both what the tissue damage and the person is, and how can we take a whole person and evidence-based approach. How about you all? I understand most of you are claims adjusters. Anything we can do to minimize delays in determining compensability of the injury itself and treatment authorization, communicating with the treaters and building relationships with us when possible, it goes a long way. It's always, you know, tempers can run high in this system, but it's always a lot harder to be mad at someone that you know, and easier to kind of get things done because you have a shared purpose of getting someone as well as they can get as quickly as possible. Another factor is kind of realizing when someone is treatment is really escalating, and seeing if there's maybe a different doctor they need to see or a different approach that needs to be taken for that worker. Talk a little bit about treatment approaches. I'm not going to spend too much time on this, but I'll just kind of introduce it, and then we'll take some questions. I want to leave time for questions. So when we talked about assessing pain, now what do we do for treatment? An analogy that comes from the American Chronic Pain Association is 4 flat tires, and each flat tire represents an opportunity to pump it back up, fill it with air. And these are different buckets of treatment modalities. So we've got our interventions, things like injections, surgery. We've got medications. We've got rehabilitation approaches, both active and passive approaches. And then we have behavioral approaches or mind-body treatment options. So we'll talk a little bit about rehabilitation approaches and then mind-body treatments, and then we'll take some questions. So with rehabilitation, there are active and passive treatment approaches. Active approaches are things that you, the patient, do yourself. Passive treatments are things that are done to you. So these passive treatments like heat, cold, chiropractic, acupuncture, traction, myofascial release, TENS, you know, massage. These are things that definitely play a role in treatment. But the pitfall is that it can foster a sense of dependence, and so if someone just depends on chiropractic adjustments, they may be missing the opportunity to engage in more active treatment approaches. I try to set expectations when I'm requesting passive treatments. You know, like let's say I'm requesting acupuncture, so I'll say something like, "We'll try to get acupuncture, massage to help reduce some of the pain, so that you can get more out of physical therapy," which is, I think, more important. Active treatment approaches are things like PT, OT, ergonomics, Tai Chi, yoga, and home exercises. I think this is really the foundation of recovery, but there are pitfalls to this too. Not all therapists are used to working with people who really have complex chronic pain, and especially have, you know, maybe lots of psychosocial factors that are impacting their recovery. And PT doesn't always feel good, and people sometimes expect that they're going to go to a PT office and the PT is going to, you know, make them feel good. or just give them a massage. And so expectation setting is really important on my end too. So I may say something like, PT is the most important thing we can do for your injury. It's not necessarily going to feel good in the short term, but it's going to help you get better in the long term. Behavioral approaches. So this is really a really important piece of chronic pain treatment. And what it all comes down to is behavioral treatments, they help change the meaning of the pain. So they help reduce the suffering associated with the pain. Sometimes that actually helps the pain go down or even disappear. But another way to think of it is like, if pain's this, monster with big gnashing sharp teeth, behavioral approaches may not get rid of the monster, but may remove some of its teeth, so it doesn't have quite as sharp of a bite. So behavioral treatments are things like cognitive behavioral therapy, mindfulness. There's different types of therapy like acceptance and commitment therapy, pain reprocessing, biofeedback, and fear avoidance belief training. These can be done often by a psychologist, but sometimes by other providers who are familiar with these methods, or even physical therapists who are familiar with these methods. An important thing is that cognitive behavioral therapy is recommended as part of treatment for chronic pain. And one thing that I encounter frequently is when I request CBT for pain, it doesn't get sent to be reviewed because they say, well, the person doesn't have a psych injury. And I mean, the way that I interpret the guides, the AMA guides, is that CBT is independent of whether they have a psych injury or not. CBT is a recommended treatment for chronic pain. So I think that's really important to keep in mind. I'm not going to spend too much time on any time on medications or interventions. That's kind of a topic for other lectures. But I'll end on this functional restoration approach. And this is what we focus our efforts on at our clinic. And I think what really gives people the best chance of recovery. And essentially what it means is you're looking at the whole person, taking all the biological, psychological, and social factors into account, and delivering treatment that's integrated. So the psychologist is talking to the doctors, talking to the physical therapist. In our clinic, with our functional restoration program, we meet every week and discuss the patients who are in it. And this is really the gold standard of treatment for chronic pain. Even so, it's not always successful. And unfortunately, this is something that's usually only approved in our system as a last resort, when oftentimes someone could really benefit from this integrated approach early on in the course of their treatment. I mean, a lot of us can really identify who's going to end up being someone who utilizes a lot of treatment in the future from the very get-go. And if we could get these people on a kind of an integrated team approach to treatment early on, I think we could avoid a lot of the disability and lost work time that we see so often in these patients. So I'm going to end here so we have time for questions.
Well, Dr. Smith, you have done a pretty darn good job, because it looks like most of those questions were answered, because I don't have any active questions right now. But I do have something that I'd like to ask you. I saw on one of those
I'm sorry if I
slides.
went off. It looks like my camera went off. So
You're back on now. We're good, and
okay.
that's fine. And now you're off again. So whatever you did, unclick that. But but you're getting some hand claps, so it was definitely a good presentation. I saw on one of those slides acceptance therapy or acceptance and commitment therapy. And my question for you is how much of a role does it play people's state of mind that they just have this belief that they're injured and that until you change that belief, you know, there's going to be a heightened level of pain, I guess. I don't know, really how to ask that in a medical format, but, you know, I know in this industry, we just see a lot of people that come to us or come to claims adjusters and they're just believe they're chronically ill. And I wonder from a doctor's perspective, how much of your state of mind and that belief plays into their treatment.
I mean, the short answer that plays it has a huge role in that, and I think the from what we know is well, we all know these people who are in a ton of pain and say they have a high level of disability, but when we look at the imaging, there's like not that much wrong, and or there is something wrong, but it's probably not the source of things. This real classic is someone with terrible back pain. They've got a mild disc bulge. They can become so fixated on this disc bulge that like this is what is causing my pain. I need surgery, and we call this somatization or somatic focus,
Mhm.
where someone really is kind of stuck in this mindset that if that they're damaged and that needs to be fixed before they can get back to life. And I think the all too often our first thought when we see these people is, oh, they're malingering, they're making it up. It's they're just trying to get out of work. Um, I, yes, that happens. Um, from my perspective, and seeing people and what I know about the neuroscience of chronic pain is, I mean, pain is real. To tell someone that they're not in pain is like completely counterproductive. So what I try to do is acknowledge the high amount of pain and suffering. Like, I am so sorry that so you're suffering so much, and no one's been able to find an answer for you. And I try to then help them shift their mindset to one
Mhm.
that is okay, one of safety. So they know that okay, they're not going to damage themselves more. Just because they're hurting doesn't mean that there's harm in the body, and that it's not useful to just, a lot of people say, well, yeah, I'll get back to work, I'll get back to life when I stop hurting. We try to change that mindset to one that is, okay, I'm hurting, and here's what we're going to do that provides a safe way to get back some function. And that really takes the team approach. Um, and it's not always successful. That's
Yep.
one of the hardest things. I mean, that's the hardest thing about my job is like when I know that someone can get better and that it's their mind just like can't get to that point. Again, I mean, yes, I think a small portion of these people are, malingering, but I just don't think that's the root of this type of scenario.
Well, you touched on the mindset, and that's where I was going with it. I personally believe mindset has a huge amount to do with things and challenging things we take on in life and getting injured and
Yeah,
being in that situation where you believe you're not going to get well or that it's overtaking your life
yeah,
and changing out of that mindset is really hard, and it all depends on the injury. But
yeah. And I want to emphasize too that that mindset, like not, well, first off, there's just a lot of stigma when we start talking about the mind or psychological factors. So when I bring this up, a lot of time, despite how many times I say I'm not doing this, what people hear is, oh, this doctor is saying it's all in my head, or I'm crazy, or I'm weak, I'm not able to, I'm not strong, you know, I don't have a strong mind. And then they kind of shut down. It's really, there's just so much stigma associated with the mind. The other thing is, just because when someone can't change their mindset, it doesn't reflect a personal failing or weakness on someone's
Mhm.
part. Sometimes it's hard to, especially when we see, you know, like media and our own lives are full of people who've like overcome challenges, but the reality is that sometimes people can't. You know, not everyone can adopt that mindset that allows them to really regain a lot of function after developing severe chronic pain. And I hope that changes. You know, I hope that science gives us more and more understanding about pain and new ways to intervene. But as it stands now, these hardest cases really take a lot of resources and a lot of different specialties to try to help.
Well, thank you for your clarification on that. You do have one, well, we're getting a lot of responses here about just great presentation here, but one question that we got, Doc, is can you explain the difference again between hurt and harm?
Yes. So um, harm, when I say harm, that is the actual tissue damage in the body. So that represents the broken bone, the you know, the disc bulge, the torn muscle. Hurt represents the suffering related to that injury. So two people could be harmed in the same way. You know, they have an identical, let's say, disc bulge or identical arthritis in their back, but the hurt or the suffering can be totally different between those two people. And what I hope I've illustrated is there's so many factors that lead into that completely different pain experience that can be felt by two different people with the exact same injury.
That makes sense.
People suffer in such different ways and for different reasons.
Well, thank you for that. Doctor, do you have anything else that you'd like to add? You know, we will get these slides. Please, everyone, download the slides if you haven't already. And do you want to let our audience know a way that they could get in contact with you, or the best way to contact you? I know I'm sure it's on the slide download.
Yeah, I'm gonna rewind back to the beginning where I have my email. So for general questions, or if we have a shared treating patient, please feel free to email me, alexsablesmithmd@gmail.com. And then I'm, you know, also available for med legal evaluations. You can always get in touch with us that way if I come up on a QME panel. So the if you want to reach out about a med legal issue, the email is drsablesmith@mlexperts.org. So that's DRSABLE-Smith@mlexperts.org. But that would just be for med legal things.
Perfect.
I'll put
Perfect.
that in the chat.
Well, everyone, I just want to remind you all that this is a 1 CEU hour class. Thank the doctor for his time to be here today. We really appreciate it, Dr. Sable Smith. And please know that you should receive your certificate within 30 minutes. Once you do, please download it right away. And if anybody needs any help or they didn't get a certificate, you can email myself or Diane, and we will look into the issue. We'll be able to provide you a certificate within 30 days, but after that, that will not be possible. And do not forget to download the documents that are attached to this webinar. I thank you all for being here. Please stay tuned for tomorrow's webinar, which is going to be at 10 a.m. And that is going to be navigating the sea of electrostimulation technologies. And that should be interesting. Myself and Diane will be on, and we look forward to seeing you then. I hope everybody has a wonderful rest of their day.
Thanks for the opportunity.
Thank you, Doctor. Have a great day.